Hi, my name is Asha Devereaux, and I'd like to share with you a presentation that was given to a group of people on Saturday, July 16th, 2022, regarding surfing the waves of COVID and long COVID. This presentation is not meant to add any fear, but more understanding of the waves of COVID, how we can survive through them, and discuss a little bit about the ramifications and symptoms of long COVID. So let's first take a look at what do we mean by the waves. What we see are these surges as denoted here by our San Diego wastewater caseload. It's important to keep in mind that no longer with the home test kits that are available are we able to accurately know exactly how many people are um, sick with COVID right now in an outpatient setting. People aren't falling ill dramatically like they did in the first 2 years of the pandemic, and so wastewater is a surrogate for how much COVID is in our environment. We are seeing that in mid-July, there is an upward trend here, and this correlates with what I've been seeing in the past 2 weeks in my office. If in the lower chart, you see that as of the first week of July, this red zone here reflects BA5, and they are doing sequencing of this wastewater, so we know that this variant is predominant. And there is some BA4 and some residual BA2. It's also important to note that within a span of just a few weeks, BA5 rapidly took over the BA2 that predominated for about 2 to 3 months. So, one question I've received from all of you: how much more contagious is this BA5 variant? This person had heard that one elevator ride with an infected person could result in an infection. Um, don't know if that was a person who had sneezed or coughed, just breathing. I'm assuming these people are all unmasked. We do know that this is a highly transmissible variant. It is being compared with measles, so therefore an elevator ride would be a sufficient amount of exposure. The BA4 and 5 variants are not quite as mild as the original Omicron number one, I should say, variant. We are seeing more predominant upper respiratory symptoms, a sore throat, headache, fever, fatigue, muscle weakness, and there may even be cardiac and cardiovascular implications associated with this variant. This is a picture of the SARS-CoV virus particles on our some of our cells in our body. So as you can tell, these virus, the SARS-CoV-2 virus, there's hundreds, millions of them when we are infected. Let's look at what we mean by the variant. The variant is the variations in the spike proteins that this virus learns to modify using us as hosts, and these genetic modifications lead to these different sequences. So this is the BA1, which was the original Omicron that was surging in January of this year. And now we have the BA5 and the BA2.75, which you may have heard about on the horizon. And the BA5 does share a couple of sequences with the BA1, but it has some novel sequences, and this L452R tends to make it a little bit more transmissible as well as evade immune escape. The BA275 is currently on the rise in India, and we don't know whether there will be out competition, if they will be in parallel, if one will, if BA5 will sustain a prolonged period here in our environment, and BA 2.75 will never get a foothold. We just don't know how this is going to end up happening, but it's important to know that this is the next subvariant that we are anticipating. And here's the headline from India from last week saying they've dubbed this variant Centaurus, the new stealth Omicron. And there have been some reports in the United States, the UK, Japan, Netherlands, and Germany that they've detected this strain. What that will mean clinically, we've yet to see. So let's talk about protecting ourselves. We do know that the CDC is advocating for people over the age of 55 or 65 to get the 4th dose. It's important to know that this vaccine is the same as our first, second, and third vaccines. That means that it was a vaccine that was made against the wild original coronavirus strain of the SARS-CoV-2, and that this spike protein has mutated to over 50 changes. We know that the vaccine could probably handle about 20, 25 mutations before it wasn't as efficacious. The goal with the 3rd dose was to get our immunity back up, because we know that with any of these vaccines, the mRNA vaccines, our immunity only lasts about 12 weeks and drops to about 40 to 60% protection. The good news is these vaccines are preventing us from the death that we were seeing in 2020. However, we are seeing plenty of escape. That means that you can have all 4 doses, but you can still get COVID. Just like, say, we have a flu shot, we're not getting as sick if we have a flu shot, but we can still get influenza. So what are the riskiest settings or in outdoor environments? I showed you a state map of the areas that are considered of high transmission. As you can tell, we are currently in the almost red zone, where the infectivity rate is quite high. We have to keep in mind that outdoors, with this BA5 variant, outdoors may not be quite as safe as we think. It depends on how congested the crowds are, how long you're in front of these crowds, how much yelling is going on, how much air movement is present, how dry or moist the environment is. So we have to be careful about outdoor concerts, movies, festivals, even barbecues, bars, and sports games. So when you're jammed together, for a long period of time, you're at risk. Another question I've received is, how reliable are the rapid antigen tests with the current variant? Well, it's interesting to note that it's taking people approximately 3 to 5 days of having symptoms before the test even is positive by the home test kits. That means the original virus that the reagents were made for, it requires more of those millions of virions particles to test a positive test. That does not mean that we should wait to test ourselves, because you may still be infecting others. So if you have a cold, then try to cancel out on that party or event and avoid trying to go out unless you wear an N95, and inform your hosts that you weren't feeling well. The PCR test is still reliable, and there is something called an S gene dropout in this variant, so it gives us a signal that the variant is circulating in our environment. We're finding also that, unlike that 5 days that Delta and Omicron 1 had, in terms of a mild, not mild course, but just a shorter activity in our systems, the positivity of BA4 and 5 can remain up to 3 weeks in our senior population. So it is advised that you still continue to try to avoid other people if you're symptomatic and still testing positive, because you could still be shedding virus. The expiration on many COVID home test kits is extended by approximately 3 months. And with the rate that I'm getting phone calls of these test kits, folks are testing positive, obviously it's working. I think should still be okay. Most medications and other medical supplies are functional well beyond expiration dates. The reagent has not been tested for duration of action, so it was a guess to even begin with to set an expiration date. But due to medical supply chain issues, we have to use what we have. So let's talk about it. So if you get COVID and test positive, what are some things that we can use? And for our most vulnerable, what are some agents that could be preventive? Well, we only have one prevention agent. It's a pair of monoclonal antibodies called Evusheld, and that is the only approved pre-exposure prophylaxis, PrEP. That is given to our most highest risk population who are undergoing active cancer treatments, immune compromised, and can't, or for some reason can't get the vaccine. And that monoclonal antibody pair will last 6 months in your system. And we do have supply in San Diego. And many of you have received this and are doing quite well. It's actually quite efficacious against our current circulating variant, especially this silgavimab portion. And we don't know how long it will be protective against future variants. If you've been exposed, I get this question a lot, is there something you can take so that you won't get COVID? Like your spouse has COVID or a child at home has COVID. Currently, there isn't anything authorized that can be taken if you are exposed to COVID. And there have been studies done with the monoclonals as well as these antivirals. And they did not pan out in protecting the individual, because even after you were taking some of it, you could still get COVID from another way. If you do have mild or moderate symptoms and you're not too sick to be in the hospital, we do have some outpatient treatment regimens that we can give you. The oral Paxlovid, which you've heard a lot about, and a Merck product called Lagevrio. And I'll talk a little bit more about that in the upcoming slides, as well as monoclonal antibody treatments. We only have one, and it's called bebtelovimab. And these are effective in helping you stay out of the hospital, which means they are doing its job. You may find that you get a prolonged illness, or you may retest positive, and we'll talk about that Paxlovid rebound. There is a drug that you can take IV for 3 days, remdesivir, as an outpatient, but it hasn't really taken off, because that means we'd have to have somebody set up at a hospital setting for you to come every day for 3 days for an infusion of drug. And these two are a little bit more convenient. I won't touch on, if you're in the hospital, what we would do for you. Want to focus more on the outpatient management of COVID. The treatments in San Diego are the monoclonal antibodies. It's open to anybody who has a positive test with symptoms under 7 days and at high risk for severe COVID, which includes people over the age of 65, pregnant women, diabetes, heart disease, high blood pressure. Clinical studies have shown that this decreases the risk of hospitalization and death by 70%. Paxlovid is another drug that's available, which I can prescribe to you. And that is carried by most pharmacies now. And in fact, just last week, pharmacists are now authorized to give this directly to patients as long as they bring their medical records with them and show their medications as well as kidney and liver function. I've received questions on antibody evasion by these subvariants and whether bebtelovimab still remains active. This was a preview article that was just released by Nature, where these authors took serum from vaccinated and infected individuals and tested and used also the drugs against these subvariants. And they found that our immunity isn't quite as good against the subvariants um, from vaccination. However, the bebtelovimab remained quite active. So that's good and bad news in the same article. So I mentioned Paxlovid rebound earlier. What is it? So we have to think about these drugs and what they do. They're not pills that we can take to kill the virus like an antibiotic would. These are antivirals, but I would say think about Paxlovid like birth control for the virus. You have all these adult viruses on that want to multiply for their survival. Paxlovid will stop that replication, but that doesn't mean the adult viruses are dead. They're still in your body and can continue to make you feel ill. And your own immunity from the vaccine, as well as your own personal strength, will help you fight and kill the virus. You may feel better after 5 days of Paxlovid therapy, and you may think you're fine, so you resume your normal exercise. And then at about day 10, you may feel sick again. We don't know if at day 5, all those adult virus particles or virus have actually cleared by the time you test negative. They may be harboring in your system, and you may get what's called Paxlovid rebound, which Anthony Fauci actually experienced and shared his experience on June 30th. And he said, after I finished 5 days, I went to negative, and then 3 days in a row. And then on the fourth day, just to be certain, he was positive again. And he did get a repeat dosing of the Paxlovid. And then at the conclusion of this article, the CDC still doesn't advise redosing with Paxlovid. But if you're at high risk, I think we have to do something to make you not have some sequela of COVID. If you've been watching the news lately, you've also seen that the FDA last week approved a vaccine by Novavax. They're calling it Nuvaxovid. And this is a differently made protein subunit vaccine. It doesn't use the messenger RNA. It's more made in a more traditional format using insects to grow the spike protein, and then using what we call an adjuvant as another chemical to strengthen our body's response to this spike protein. And it's similar to most other vaccines that you've likely received, like the tetanus shot, hepatitis vaccines. So we anticipate this distribution following the CDC's approval in the upcoming weeks. The US government has purchased about 1.5 million doses. Based on survey data, only about 20% of people who have not received the vaccine yet would even consider getting this vaccine. This may also be a useful vaccine for people who didn't tolerate their first 3 doses and may want to use this as a fourth. To be fully vaccinated, it requires 2 doses, 3 to 4 weeks apart. This is a study that was released early this year, but on this vaccine from the US and Mexico, they had over 30,000 people um, enrolled, and about 25,000 patients received both doses of the vaccine. It's important to keep in mind that the study was performed between December 2020 to February 2021, when the B117 and Delta were um, circulating. So we don't know how well it would work against Omicron or any of those subvariants. The main thing to note is everybody wants to know, what are the adverse effects? The local skin reactions, sore arm, did occur in up to 79% of people, and maybe a little bit of a mild fever or fatigue occurred in a good number of people. It's interesting to note, after the first dose, it was similar to placebo. The vaccine was proven to be quite efficacious in preventing COVID-19. On July 1st, Novavax said that they anticipate broad immune response against all the variants, including BA5, in clinical data that they have not released publicly yet. But some experts are optimistic that it might outperform the mRNA vaccines against BA5, owing to its technology. It's hard to practice medicine by these company press releases. I'd love to see the data when it's released. But this does look promising in terms of its overall efficacy against COVID-19 in vaccinated versus non-vaccinated and individuals. So I mentioned Evusheld earlier for people who can't be vaccinated or are immune compromised. And it is a monoclonal antibody that lasts approximately 6 months or perhaps longer, will require redosing. And the folks who are qualified to receive this are people who have not been currently infected with SARS-CoV-2, although there was a study released that shows this can be used if you are in the midst of an infection, but it's really expensive, more expensive than bebtelovimab, and I would not recommend this as an active treatment. But if you received it and then got COVID, you can consider yourself treated. If you have moderate to severe immune compromise due to medications or chemotherapy, or if you had a severe allergic reaction to one of the prior COVID vaccine or components of that vaccine. So if you qualify for this, or many of you got the vaccines previously and now have a new diagnosis of cancer, this would be something to consider to add on. How will you receive it? So I send an order in. Sharp has received Evusheld, and they are administering approximately 4 patients a day with this drug. So we will submit your information to Sharp, and they have meetings, and then they line folks up according to their criteria in terms of priority indications, and they'll call you for your appointment. And please, 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 if they call you, take that appointment. Because our goal is to treat COVID as aggressively as possible so that you don't develop what's called long COVID. This is a very difficult term. I like to say that we have short, medium, and long COVID. And short period is the acute symptoms until you test negative. The medium period is within the first 3 weeks to 12 weeks, where you're still in somewhat of a recovery mode. And then 3 months or longer, some people have ongoing fatigue or shortness of breath. Some people, it takes a long time to regain their sense of smell or taste. Some will have muscle weakness or pain. Cough, I can personally attest that my cough would last 60 days. Memory loss, mood changes, sometimes dizziness are all part of symptoms that people are experiencing 3 months or beyond. These manifest in things called brain fog, the prolonged cough. The virus, like any other virus, can turn on asthma. It can create pneumonia and lung disease and scarring. Some people have resulting hypoxemia or oxygen requirements. Like other viruses, it can turn on autoimmune disorders as well as arthritis. The novel part of this SARS-CoV-2 virus is that it makes us hypercoagulable, and so with an increased risk for blood clots. Fatigue, kind of like how EBV was associated with chronic fatigue syndrome, we're seeing something similar here. The taste can change. You may not lose your taste completely, but you can suddenly, out of the blue, taste something bitter that wasn't bitter. It can affect the heart um, by developing cardiomyopathy, or even an arrhythmia can develop after COVID. So this is the reason we want to try to avoid getting COVID if we can, and then treat it so that we don't have prolonged symptoms. So why does this happen? Well, we don't know exactly why. We can't do a blood test and measure how much virus you have, but there's a thought, well, maybe there's still residual virus hanging around in our system that just kind of stays turned on. We know that the tuberculosis virus can go latent, or even herpes simplex virus or the zoster virus can be latent in our systems, and maybe we have this latent virus that's just kind of keeping us down. There could be what we call a chronic inflammation resulting from this, that then just we're always trying to fight this particle. Or did it turn on a gene that then created an autoimmune process? So there's lots of smart people doing research on trying to figure out why this is happening to us. We don't even know how long COVID is going to be around. And there's a big concern that a lot of people have these symptoms and are underreporting. So somebody wanted to know how long, or what are the risks of long COVID, and does it go away? Does it take weeks, months, years? Or is age alone a risk factor for developing long COVID? And I like to say that it's really hard to estimate. Right now, long COVID can be sequela of COVID pneumonia. And as with any hospitalization, you're not quite the same again. And is that long COVID if that's a sequela of damage done versus you got a mild infection and now you've developed weakness and memory loss? So the definitions still are in a state of flux, but it ranges, depending on how you define this, anywhere from 10 to 30% of people infected. There seem to be some risks for developing long COVID, people who have underlying autoimmune disorders, those who tried to push through their COVID, kept exercising through it, tend to not have as good of a recovery if you had severe symptoms or if you were hospitalized. We do see that symptoms do improve with time. So it's important to follow your symptoms. So rest when your body tells you it needs to rest. One description is that you go for a workout, and then you feel like taking a nap. Well, take that nap and let your body rest and recover. Many people are advocating ashwagandha, which is an Ayurvedic supplement that's supposed to help protect the nerves, and other supplements from nutraceutical industries to help with their long COVID symptoms, because they are feeling like they got to be doing something to help themselves. But check with me first if you're going to be reaching into that arena for some type of support, because we don't want to miss anything else going on in your body. Now, a lot of people are getting reinfected. And what about reinfection? What does that do for your risks for developing long COVID and or overall risk? So this was a preprint just published in June, and it's a study, a retrospective analysis of millions of people in the VA health system. And they looked at 250,000 people with the first infection and about 40,000 with reinfection and then with non-infective controls. And they showed that compared to people with the first infection, those who had been reinfected had an increased risk for all-cause mortality, hospitalization, and some other pre-specified outcomes. And they noticed that even in the acute and post-acute phases, they saw pulmonary, cardiovascular, renal disorders, and blood clots. The data is still in peer review. This was in one of the preprint websites that we can access when we see, just so that information can be shared amongst clinicians. But it's still undergoing peer review, and I look forward to reviewing this data. I also have found that a lot of people are quoting things that were written and became dogma last year when the virus behaved differently. Now, with this highly transmissible variant that takes a while to test positive with, that lingers in our system a little bit longer, some of this dogma that we kind of cemented in our mind, we need to reconsider. So, one thing is that does 2 doses mean we're fully vaccinated? No. Now we're recommending a 4th dose for folks just to boost up their immunity to protect them against hospitalization, which is now the purpose of these vaccines. It doesn't mean you won't get COVID, it's just you won't get as sick. Also, based on what we are learning about this variant, 6 feet in 15 minutes equals a close contact. It may be 5 minutes and somebody's coughed on you, and that may be just enough. And it could be walking by somebody, or you could even walk into an elevator that somebody had been coughing and sneezing in. And we've learned that the virus can persist in the air in a closed space for about 20 minutes. What about 5 days? And that means you're ending your isolation. Well, if you just tested positive on day 5 and you're still feeling ill, that should not mean you've ended your isolation. You definitely should be wearing an N95, but I would argue that even if you're feeling sick and you're out and about at day 5, then you're going to pull your mask off, touch things, and talk to somebody, and you may expose folks. And we used to not retest folks at 90 days if you've been recently infected, and that would be the PCR, but maybe we should reconsider that because people are now getting reinfected within 30 and 60 days with these new variants. And then these masking numbers about hospitalizations means you get a certain number of cases and hospital admissions, and that means you mask up. And the sheer numbers of people infected may be a reason to mask up, and we've just found that the military on Coronado, the base is now, as of today, starting to advise people to mask to go in public spaces. So we are seeing our remasking occurring. Many of you are traveling. What can you do? Right now, there are no travel restrictions on testing pre or post travel. So I think we have to travel. We've been isolated for 2 years, and it is not healthy for our families and our mental health. I would anticipate getting infected, so be flexible with your plans. You may end up at your destination a little longer than you planned. Call me so we can treat you at the earliest in order to minimize any sequelae. Many people do have mild symptoms while others are sick for 1 to 2 weeks. We just don't know how to predict it. It may depend on how much viral load you've inhaled, what your underlying risk factors were, how how much you slept, what was your immune system at the time. And so we still don't know who's going to have mild symptoms versus who's going to be ill. Um, have fun in between these waves of COVID. Enjoy if you've recently recovered from COVID of this variant, then you're in a bit of an immunity bubble. This is all that's circulating, so this may be your opportunity to travel, and maybe you should take advantage of it before the 2.75 comes down the pipeline, and if we learn that this variant and infection is not carrying over in terms of immunity to a subsequent variant. So I share with you the slide that we've been showing from day one about aerosol transmission and why just doing the common sense of wearing a mask to all of the medical office visits, we're not going to stop using masks in the medical office. It's been nice for me as a provider not to get the flu or infections in the office. We have not had any office transmission of COVID, which, knock on wood, I'm grateful for. And that's because the staff and I remain masked. And our patients are advised to mask because you may have a minimal cough, think it's allergies, and you could be infected, and a potential host can inhale the virus. So a mask may not prevent us from getting infected, but maybe the viral load will be a lot less. And maybe if we had our own immunity helping us, we may fight it and not even realize we're infected. So for that reason, masking still remains in all medical offices. Many people are surprised they didn't get COVID yet. And they've lived an unmasked life, or they had been in the same room with their spouse who was active with COVID. And they wonder, what about that blood type study? Interestingly, and I'm waiting to see whether this pans out through all the variants, there was a higher risk in blood group A than in the other blood groups, and it seemed like there was a protective effect in the blood group O as compared with the other groups. This was from China in 2020, and then from Harvard, they also looked at 1,800 people, and they didn't say that one blood group type had more severe illness versus another, but they also found a similar correlation that the O blood type, those folks didn't tend to get infected. I'd love to see the follow-up studies to this. So with that, I thank you for your time and appreciate your attention, and will be happy to take any questions if you want to email me or call me. Thank you, and have a good day.